Assalamu alaikum. This is Dr. Anna, and today presentation is about epilepsy and its management in pregnancy. So it's very important guideline. This presentation is made from Green Top guideline, and this is very important guideline because um, no exam of part 2 or part 3 is without epilepsy. Either it's a multiple choice question or it in the is they will if there is a station of emergency contraception, so they will have the patient who is having epilepsy and taking enzyme inducer or non-enzyme inducer. They want to check, they want to see whether you know that the hormonal emergency contraception can be given in patient of epilepsy or not, and what is the dose of emergency contraception. So, and also the management and what are the important points and management in labor and what painkiller should not be given in patient with epilepsy in labor, because epilepsy is very easy but very important guideline. So the main important thing is, the patient who is having epilepsy has been diagnosed before pregnancy, obviously, because they know it for the long time, and mostly they know all the management options. They are well controlled if they are, but if they are not well controlled, even then they know what triggers them. They know what is the triggering factors. So you just need to recounsel them before pregnancy and emphasize that this should be prevented, so that your seizure will not, you will not have seizure again in pregnancy. So diagnosis of epilepsy is made by the neurologist, and it's not made by gynecologist or obstetrician. So everyone should know about the epilepsy and its type. Diagnosis of epilepsy and epileptiform seizures should be made by a medical practitioner with expertise in epilepsy, usually a neurologist. Women with epilepsy, this term is used in the guideline WWE. Women with epilepsy, their families, and health care professional should be aware of different types of epilepsy and their presentation to assess the specific risk to mother and baby. Epilepsy is one of the most common neurological condition in pregnancy with prevalence of 0.5 to 1%. Any assessment of condition in pregnancy should include duration, severity, frequency and type of seizures, impact of epilepsy on mother, such as driving, accidents, family life, and employment. A drug history of effective and ineffective medication is relative, including a history of adverse effects. Patient is having anti-epileptic medication. She tried one medicine, but there was no control of epilepsy. So they might have changed it, or they might have added another anti-epileptic. So it's very important to know which medicines worked or which does not. Mortality in women with epilepsy, the risk of death is increased tenfold in pregnant women compared with the risk of death is increased tenfold in pregnant women with epilepsy compared with those without the condition. 14 maternal deaths that occurred between 2009 to 2012 were attributed to epilepsy in 2014, Embrace UK. 12 among these 14 deaths, 12 of these 14 deaths were classified as SUDEP. SUDEP is sudden unexpected death in epilepsy, with poorly controlled seizures being the main contributory factors. So types of epilepsy are tonic-clonic seizures. I will just tell about the few features that can differentiate from one another. But generally, this management is related to neurologist. And in pregnancy, a patient when comes in the preconception clinic, she tells you that I'm having epilepsy and I'm having this medication. You will screen the patient that is it her disease is controlled or not, her condition is controlled or not. So you will ask the frequency of seizures, And if you see that patient is taking anti-epileptic, which is not good for pregnancy, and it needed to be changed, we will not change it. We will refer the patient to neurologist, and neurologist will assess the condition of patient, and then he will modify it. An anti-epileptic drug is not to be changed by us, obstetricians. So types of epilepsy: tonic-clonic seizures, previously called as grand mal seizures. Dramatic state of stiffening followed by bilateral jerking. Post-seizure state of confusion and sleepiness. Absence seizures, generalized seizures that consist of brief effects mediated through brief loss of blank spells associated with unresponsiveness, which are followed by rapid recovery. Juvenile myoclonic epilepsy. Myoclonic jerks are key features, often precede tonic-clonic seizure. And then focal seizures, previously defined as complex partial or simple partial. Symptoms are variable and aura is the primary focal lesion. So we can categorize the patient in the low-risk epileptic woman and high-risk epileptic woman. So low-risk epileptic women are those which can be considered as generally their care is similar to the patient, a normal patient, with a woman without epilepsy. So how can we tell that this patient which was having epilepsy, but now it's a low risk? So women with a history of epilepsy who are not considered to have high risk of unprovoked seizures can be managed as low risk women in pregnancy. Women who have remained seizure-free for at least 10 years with the last 5 years of anti-epileptic drug. And those with the childhood epilepsy syndrome who have reached adulthood. And seizure and treatment-free are considered no longer to have epilepsy. So medical practitioner with specialist training in epilepsy, usually a neurologist, should also make the decision regarding the resolution of epilepsy on an individual basis. So this decision should be made by neurologist that this patient is now is not having her treatment. She's not having epilepsy anymore because her seizure and treatment free for the long time. So this decision should be made by neurologist. And high risk epileptic women, uncontrolled tonic-clonic seizures are the strongest risk factor for SUDEP. So the patient who are having uncontrolled tonic-clonic seizure, these are high-risk patient in pregnancy, and which are the main cause of death in pregnant women. So SUDEP is generally because of uncontrolled epilepsy, and SUDEP is defined as sudden, unexpected, witnessed or unwitnessed, non-traumatic and non-drowning death in patient with epilepsy, with or without evidence for a seizure, and excluding documented status epilepticus, in which post-mortem examination does not reveal a toxicologic or anatomic cause of death. So this is the patient silent death of the epileptic woman. So patient can die anytime. But we should be after the post-mortem examination, we are not able to find any cause of the death. There can be seizure or cannot be seizure. So this is called as SUDEP. Other conditions in pregnancy should be considered in differential diagnosis of epileptic seizures. So there are two types of patient. One is patient with the non-epilepsy, and other if the patient comes in pregnancy with seizure first time. So we are not sure that she is having epileptic seizure or not, or she's primarily if the patient present in pregnancy, especially in the second half of the pregnancy, we will manage the patient according to lines of eclampsia, unless proved otherwise. If you feel with the treatment of eclampsia, the patient is not improving with magnesium sulfate and blood pressure is normal, no proteinuria, then you will involve neurologist. And then neurologist will assess the patient and he will make the diagnosis of epilepsy. If in making a diagnosis, if he needs to have a CT scan or MRI, it can be done for the patient, because single exposure to CT scan and MRI in the pregnancy is not considered as dangerous as if we are not able to make the diagnosis for epilepsy. So if the patient, one is that she comes in pregnancy in the second half, it's eclampsia first in list, and then epilepsy, and then other these conditions. And if comes in first half of pregnancy, obviously there is no eclampsia, then these are the conditions which can be considered other than epilepsy if patient is not having history of epilepsy. In pregnant women presenting with seizure in the second half of pregnancy, which cannot be clearly attributed to epilepsy, immediate treatment should follow existing protocols for eclampsia management until a definitive diagnosis is made by a full neurologic assessment. The diagnosis may be dependent on past history of epilepsy or on risk factors for developing preeclampsia. So we will see whether she is having epilepsy. If not, is she having preeclampsia or raised blood pressure, proteinuria? Then we can see on which side diagnosis is going. Other cardiac, metabolic, or intracranial conditions, neuropsychiatric conditions, including non-epileptic attack disorder, should also be considered in differential diagnosis. MRI and CT scan can be considered safe in pregnancy to assess women presenting with seizures. The risk to fetus from a single exposure is minimal. So now I have made that patient, I've made it clear that patient came in pregnancy. She's not having history of epilepsy and she has presented with seizure. So we will, if the second half of the pregnancy, we will manage on the guideline of pre-eclampsia. Eclampsia, if it's not getting better, then we will we will have the other list in our mind, which include epilepsy and all these other risk factors. Cerebral venous sinus thrombosis, posterior reversible leukoencephalopathy syndrome, space occupying lesion, reversible cerebral vasoconstriction syndrome, other conditions such as syncope associated with cardiac arrhythmias, aortic stenosis, carotid sinus sensitivity, vasovagal syncope, and metabolic conditions such as hypoglycemia, hyponatremia, and Addisonian crisis. Non-epileptic attack disorder, also referred to as psychogenic non-epileptic seizure, with or without epilepsy, that require multidisciplinary management with access to psychological and psychiatric services. So sometimes patient is having epilepsy. Along with that, patient is also having non-epileptic attack disorder. So patient can have these disorder with epilepsy or without epilepsy. If it presents with epilepsy, then it's a complex condition and management is complex. So we will involve the psychiatric as well in the management of that patient. So now I have described the types of epilepsy and who will make the diagnosis. So it's a neurologist who will make the diagnosis, and neurologist will give the medication and monitor the patient. So regarding the monitoring of the symptoms of patient, if patient is being given anti-epileptic drug, and so neurologist will see that the clinically patient is improving or not. So if he will titrate the dose and the type of anti-epileptic according to clinical symptoms of the patient. So these are the patient which generally knows the risk factor which can trigger the seizures. So when patient come in pre-pregnancy clinic, so we will in this, as I have mentioned, that patient with any medical condition when comes to us in pre-pregnancy clinic. So in that clinic, counseling is very important. We will tell the patient that what it means to have a pregnancy with this condition, how this condition will affect your pregnancy and how your pregnancy will affect this condition. And then we will tell the patient she should be in best of her health, and she should be given folic acid according to her needs. If she needs 400 microgram or 5 milligram, we will see according to the condition she is having. Then we will tell the patient what pregnancy care will be done for her during the course of pregnancy. We will discuss whole plan of pregnancy with the patient. And we will tell her if what are the symptoms, what are the triggers which can increase the risk of, like in this patient, what can increase the risk of seizure in the pregnancy, and what are the implications of having seizure in pregnancy. So basically, this is all counseling pre-pregnancy clinic. So patient knows what she is asking for, and she should be ready for that. So pre-pregnancy counseling and management under care of neurologist competent in management of epilepsy. So this will be the multidisciplinary approach in the pregnancy. Patient is already under care of neurologist. So women with epilepsy should be reassured that most mothers have normal, healthy babies. First, we should give hope, obviously. Most mothers have normal, healthy babies, and the risk of congenital abnormalities, malformation is low if they are not exposed to anti-epileptic drugs in periconception period. So we know that anti-epileptic drugs such as sodium valproate has increased risk of neural tube defect in the babies of women with epilepsy. So we will tell the patient that if she controls her condition, and if she is compliant to her medication, and if she's not taking any, just in case she is taking, but in epileptic drug, first we will compare the woman with epilepsy and woman without epilepsy. What are the differences? And then we will say, if the patient with epilepsy taking anti-epileptic drug and not taking any anti-epileptic drug. If patient is not exposed in the periconception period to anti-epileptic drug, there is no increased risk of congenital abnormality. Because incidence of major congenital malformation is similar to the background risk for general population. So in the normal population, the risk of malformation, spontaneous malformation is 2.8%. So this is the same for the woman with epilepsy who is not taking anti-epileptic drug in the periconception period. But we should tell the patient she should not skip her medication, because having the seizure in pregnancy has more adverse effect than adverse effect of anti-epileptic drug. So we will, in the preconception clinic, we will tell the patient, you should get pregnant in the best of your health, and you should be compliant to your medication. We will see whether your medications have increased risk of congenital malformation, and we will talk to your, we will discuss your management with your neurologist, whether these medication can be changed to some other medication or not. If they can be changed, that's very good. But if a neurologist says that this woman is only controlled on this medication, like sodium valproate, and it cannot be changed, so we will make sure that we will, with sodium valproate, we want to reduce the risk of neural tube defect and other side effects, because we know the risk of seizure is more dangerous for the woman as compared to the exposure to anti-epileptic drug. So we will tell the patient that you will not leave the medication, because it is the main problem in the women with epilepsy who is taking anti-epileptic drug, because they feel that if they don't use this medicine, it will help their baby. So they stop taking medication. So we will emphasize the patient, you will not stop taking medication at any time. So we can use other method, like we can give the folic acid high dose. We will, when we will see the, we will do the 20-week scan, we can see, and the booking scan, we can see any neural tube defect in the baby. You will be given option to terminate the pregnancy and plan accordingly. But she should not stop the medication on her own. So, and one thing is she is taking anti-epileptic, and which anti-epileptic she is taking, it increases the risk of malformation. What is the dose of anti-epileptic? Because lower dose is better. And the third thing is, if she's taking polytherapy, she's taking different epileptic drugs, anti-epileptic drugs to control her epilepsy. More type of drugs and more dose, there is a more risk of congenital anomalies. Risk of congenital anomalies in the fetus is dependent on the type, number, and the dose of anti-epileptic drug. So most common major congenital malformation associated with anti-epileptic drug are neural tube defects, congenital heart disorders, urinary tract, skeletal anomalies, and cleft palate. Sodium valproate is associated with neural tube defects, facial cleft, and hypospadias. Phenobarbital and phenytoin with cardiac malformations, and phenytoin and carbamazepine with cleft palate in the fetus. So they can ask the question, specific congenital abnormality with a specific anti-epileptic drug. Among anti-epileptic drugs, lamotrigine and carbamazepine monotherapy at lower doses have the least risk of major congenital malformation in the offspring. So as I have mentioned that we will shift the patient in the preconception to the safer anti-epileptic like lamotrigine. But what will we do if the neurologist knows that lamotrigine does not work for this patient completely? So her seizures are controlled only with the sodium valproate. So we cannot change it back to the lamotrigine, because unstable condition of the patient is more riskier for the pregnancy. The risk of recurrence for major congenital malformation are increased 16.8% in women with epilepsy with previous child with major congenital malformation. So there is another risk factor. like if she is having previous baby affected with congenital abnormal formation. One was type of anti-epileptic, second was dose of anti-epilepsy drug, and third was polytherapy, and fourth is his previous child is also affected. There are no significant association between epilepsy type and tonic-clonic seizure in the first trimester and the major congenital malformation. Tonic-clonic seizures can be associated with SUDEP, but they are not associated with major congenital malformations. These are anti-epileptic drugs not only affect the development of the baby and cause congenital abnormality, but they also have long-term neurodevelopmental outcomes of exposure to anti-epileptic drug and maternal seizure in infant born to women with epilepsy. So long-term effects are babies of women with epilepsy. They have, if they are exposed in utero to sodium valproate, possible adverse impact on long-term neurodevelopment of the baby. They have low IQ, low verbal IQ, and low performance IQ. So in utero, exposure to sodium valproate is associated with increased rate of childhood autism. So they can ask in exam that what anti-epileptic drug is associated with autism. Carbamazepine, lamotrigine does not appear to adversely affect the neurodevelopment of the offspring. Very little evidence for levetiracetam and phenytoin. Little is known about other new anti-epileptic drugs or combination therapies, and absence of data should not be taken as indication of fetal safety, because in some anti-epileptic drug, they have said no, little is known and no research, no evidence has been seen, but studies are limited. So when studies are limited, this does not tell us that this drug is safe in pregnancy. It means that more research is required. To what extent can congenital abnormalities be minimized in women with epilepsy? As we have told that patient is taking anti-epileptic drug, it's very necessary for her. If we have tried our best to keep it single drug, monotherapy, and low dose, and type of anti-epileptic drug, but still she is taking, if it's not controlled in, she need higher dose, or she needs sodium valproate or any drug which increase the risk of congenital abnormalities, what can we do to prevent it? So all women with epilepsy should be advised to take 5 milligram per day of folic acid. As I have mentioned in the previous presentation, 400 microgram is available for the patient. She can buy it on its own, but 5 milligram per day needs prescription. So if we will not tell the patient that, and we will not give the prescription, it's not understood that patient is taking it already. So she needs 5 milligram per day of folic acid prior to conception, and to continue the intake until at least the end of first trimester to reduce the incidence of major congenital malformation. First step, folic acid. 5 milligram folic acid is helpful in reducing the risk of anti-epileptic drug-related cognitive deficit. It's not only decrease the risk of congenital malformation, but also cognitive defects, reducing in the problem of cognitive defect. Lowest effective dose of most appropriate anti-epileptic drug should be used. This is another thing which can we do to prevent the congenital abnormality. Exposure to sodium valproate and other anti-epileptic drug polytherapy should be minimized by changing the medication prior to conception, as recommended by an epilepsy specialist. So it is always mentioned that the dose should be changed. Dose and medication will be changed as recommended by an epilepsy specialist after a careful evaluation of the potential risk and benefits. What is the effect of pregnancy on seizure in women with epilepsy? So we have, how can pregnancy affect on the frequency of seizures? If the risk of maternal seizure deterioration from changing the anti-epileptic drug is deemed to be high, women will need to be advised to continue the sodium valproate or anti-epileptic drug polytherapy. As I have mentioned, that having the seizure in pregnancy is more detrimental to the patient as compared to anti-epileptic drug. So we will tell the patient the frequency of seizure in the pregnancy. We will tell the patient that 2/3 will not have seizure deterioration in pregnancy. 67% will remain normal with this proper care. who have experienced seizure. So what increase the risk of women, what increase the risk for women to having seizure in the pregnancy? If the woman, we will always ask the patient in the preconception and in the pregnancy, when was the last seizure? Because this duration is very important for the management and prediction that she is a high risk of having seizure in the pregnancy or not. We will ask the patient who have experienced seizure in the year prior to conception, require close monitoring for their epilepsy. So she should, if she is not having we will ask in the preconception clinic, when was the last seizure? She said 1 year back, before 1 year. Then it means that she remains safe in pregnancy if we have the proper care for the patient. The seizure-free duration is the most important factor in assessing the risk of seizure deterioration. Women who were seizure-free for at least 9 months to 1 year prior to pregnancy, 72 to 92% continued to be seizure-free in pregnancy. Idiopathic generalized epilepsy were more likely to remain seizure-free, 75%, than those with focal epilepsy. Status epilepticus is defined as 30 minutes of continual seizure activity or a cluster of seizure without recovery. Currently, there are no tests to predict the risk of seizure deterioration in pregnancy. So these are still we are doing the preconception counseling. You see, it's very important to tell the patient and assess the patient in the preconception clinic. If you are able to do and manage the patient properly in the preconception clinic, pregnancy will be very easy. How should risk be communicated to women with epilepsy? We will not only verbally communicate, but we will give the written information on prenatal screening so that patient will not forget any point. The risk of self-discontinuation of the anti-epileptic drug, we will give it in the written form that you should not self-discontinue the anti-epileptic drug. Effect of seizures and anti-epileptic drug on fetus and on pregnancy, breastfeeding and contraception. Introduction of a few safety precautions may slightly reduce the risk of accidents and minimize anxiety. Any information on prenatal screening for major congenital malformation should highlight the detection rates, limitation of the test performance, and implications such as termination of pregnancy. If you have this test, we intend to find the any congenital malformation. If it's not compatible with life, then you will be given the option of termination of pregnancy. So this is the preconception counseling. It is very important. As I mentioned, if you are able to communicate this to the patient, the risk of avoiding the risk factor, advantage of avoiding the risk factor is a lot, and she should be compliant to all suggestion in the preconception period. So now we will discuss the antenatal care of the patient.